Good afternoon, everyone. Today I'm presenting my journal club and my moderator is Dr. Mohan Dyanis.
Before we start, all of you read this article.
The title is Long-Term Cariprazine Treatment for the Prevention of Relapse in Patients with Schizophrenia, a randomized, double-blind, placebo-controlled trial. The source is from Schizophrenia International Research Society, year 2016, volume 176, issued on 2 October 2016, pages 264 to 271, first received on 18th of March 2016. Final revision was on 21st of June 2016, and the article was finally accepted on 23 June 2016. Funding supported by funding from Forest Laboratories and Allergan affiliate. Allergan, it is a America-based pharmaceutical manufacturing company, and Gedeon Richter, Forest Laboratories. These both were involved in the study design, collection via contracted clinical investigator sites, analysis and interpretation of data, and the decision to present these results. So about the Schizophrenia International Research Society. It is a journal of choice for international researchers and clinicians to share their work and the global schizophrenia research community. The journal publishes novel papers that really contribute to understanding the biology and treatment of schizophrenic disorders. The impact factor is 4.5. Now, something about the Creative Commons. It is an international non-profit organization that empowers people to grow and sustain the thriving commons of shared knowledge and culture we need to address the world's most pressing challenges and create a brighter future for all. It provides with better sharing that is contextual, inclusive, just, equitable, reciprocal, and sustainable. It empowers individuals and communities around the world by equipping them with technical, legal, and policy solutions to enable sharing of knowledge and culture in the public interest. And this strategy is creating a brighter future through better, more ethical sharing. The authors of the article are corresponding author Suresh Durgam, Allergan, Harborside Financial Center, Jersey City, USA. Billy Lee, Allergan, Jersey City, New Jersey, USA. Bru Lee, Allergan, Jersey City, New Jersey, USA. Deong Lee, Allergan, Jersey City, New Jersey, USA. Kaifeng Lu, Allergan, Jersey City, New Jersey, USA. W. Wolfgang Fleischacker, Department of Psychiatry, Psychotherapy, and Psychosomatics, Medical University, Innsbruck, Austria, and Henry A. Nasrallah, St. Louis University, St. Louis, USA. Now the introduction. Schizophrenia is a serious neuropsychiatric syndrome that often has a severe and chronic course. It substantially contributes to the burden of disease attributable to mental health disorders globally. Relapses in schizophrenia are common, with each subsequent event contributing to clinical deterioration, including worsening of symptoms, cognitive impairment, reduced social and vocational functioning, and diminished quality of life. Although long-term antipsychotic treatment may substantially reduce relapse risk in the stable phase of schizophrenia, partial or total non-adherence to medication is a ubiquitous clinical problem. Prevention of relapse is an integral component of comprehensive schizophrenia management. Now, cariprazine is a dopamine D3 and D2 receptor partial agonist antipsychotic with preferential binding to D3 receptors. Unlike other newer generation antipsychotic, which have a high occupancy on D2 receptors but low or negligible occupancy on D3 receptors, cariprazine shows high and balanced occupancy of D3 and D2 receptors at doses effective for the treatment of psychosis. The pharmacological profile may provide benefits in treating cognitive impairment, negative symptoms, and mood symptoms associated with schizophrenia. Cariprazine also has a unique pharmacokinetic profile. It has two major active metabolites, desmethylcariprazine and didesmethylcariprazine. So the effective half-life for the total active moieties, which take into account cariprazine and the two major active metabolites, is approximately 1 week. The longer half-life, it may confer to some continued effect after drug discontinuation, perhaps providing protection against rapid onset of relapse in cases of non-adherence. The efficacy of safety of cariprazine in patients with schizophrenia have been supported in 3 positive randomized placebo-controlled phase 2 and 3 clinical studies. The current study was designed to assess the efficacy, safety, and tolerability of long-term treatment with cariprazine for preventing symptomatic relapse in patients with schizophrenia. And this article was cited 124 times. The aim of this study is to assess the efficacy, safety, and tolerability of long-term treatment with cariprazine for preventing symptomatic relapse in patients with schizophrenia. Now we will study about the methods and about the patient selection in the study. This study was conducted from 2011 to 2014 in 72 centers in United States, India, Romania, Slovakia, and Ukraine in accordance with the declaration of Helsinki and ICH guidance, that is International Council for Harmonization of Technical Requirements of Pharmaceuticals for Human Use guidelines. Sites obtain institutional review board, US centers or ethics committee or government agency, non-US centers approval before the study. All the participants provided written informed consent. To identify the early signs of relapse and ensure patient safety in the event of relapse, patients were required to have up to 2 consented caregivers who also assisted with hospitalization discharges, medication compliance, and study visits. Now, this is the study design. It was divided into 5 phases. The first one was the screening phase, which lasted for up to 7 days. In this, no study drug was given, and in this, the eligibility of the patient was assessed. That is all the inclusion and exclusion criteria, which we'll study further in the presentation. Then there was flexible dose open label run-in phase, which was for 8 weeks. Patient in the flexible dose, on day 1, 1.5 milligram per day of cariprazine was given. On day 2, the dose was increased to 3 milligram per day. Subsequently, on day 6, the dose was increased to 6 milligram per day. And on day 10, up till 9 milligram of per day, it was a flexible dose open label run-in phase, and it lasted for 8 weeks. And the flexible dose cariprazine 3 to 9 milligram per day was continued through week 6 of the run-in phase. Fixed dose cariprazine 3, 6, or 9 milligram per day was administered for weeks 7 and 8. For the last 2 weeks of the flexible dose, the dose was kept same, that is 3, 6, or 9. Then during the open label stabilization phase, which lasted for 12 weeks, in this, the dose was either fixed to 3 milligram per day or 6 milligram per day or 9 milligram per day. No adjustment was allowed. And at the same fixed doses as in the last 2 weeks. The last 2 weeks of the flexible dose, either the dose would be 3, 6, or 9. The same dose were continued in the stabilization phase also. During double-blind treatment, cariprazine was administered at the same fixed doses as it was given in the stabilization phase. So in 26 to 72 weeks, it was a double-blind phase in which the patient was randomized either to the placebo drug or to the cariprazine drug, and which was followed by a safety follow-up phase of 4 weeks in which no study drug was given and the safety assessments were done. So it was basically divided into 5. So as we studied here, from flexible dose open label run-in phase, when the patient goes from this phase to the stabilization phase, then also the patient has to meet an eligibility criteria. That was PANAS's total score less than equal to 60. At least 20% decrease in the PANAS's total score from the baseline should be there. Clinical Global Impression Severity of Illness Scale, CGIS, score less than equal to 4. Score less than equal to 4 on each of the 7 PANAS's items. That is delusions, conceptual disorganization, hallucinatory behavior, uncooperativeness, suspiciousness, hostility, and poor impulse control, and no significant tolerability issues. The patients was hospitalized during the screening, and for the first 2 weeks of the run-in phase, they were then either discharged and follow up as outpatients or hospitalized for 2 additional weeks. Patients unable to be discharged after 4 weeks, they were discontinued due to insufficient therapeutic response or unavailability of a caregiver. And as per the protocol, the double-blind treatment for all the active patient was stopped when the last randomized patient completed 26 weeks of treatment, regardless of the number of relapses. Investigators and patients were blinded to the double-blind treatment assignment through an interactive web response system. Identically appearing treatments were used. So for the patient, the inclusion criteria was any male or female inpatient 18 to 60 years of age. According to the DSM-4 TR, the diagnosis of schizophrenia should be met and the minimum duration of illness should be 1 year. A current psychotic episode of at least 4 weeks of duration, and patient additionally has a PANSS total score of more than equal to 70 and less than equal to 20, that is between 70 to 120, and a score of more than equal to 4, moderately severe, on at least 2 PANSS positive symptoms: delusion, hallucinatory behavior, conceptual disorganization, or suspicious. Now, the exclusion criteria was meeting any other criteria of any other psychiatric disorder like schizoaffective disorder, schizophreniform disorder, bipolar 1, bipolar 2 disorder, borderline and antisocial personality disorder, or any other DSM-4 TR Axis 2 disorder of sufficient severity to interfere with participation and substance use and dependence within the 3 months. Treatment-resistant schizophrenia over the last 2 years, that is, little or no symptomatic response to more than equal to 2 courses of antipsychotic treatment of adequate duration at a therapeutic dose, at least 6 weeks at the dose according to the package insert. Then the physical examination findings were abnormal, or abnormal findings were judged to be clinically significant. Positive results from the blood alcohol test or from urine drug screen for any prohibited medication. History of intolerance or hypersensitivity to an antipsychotic or designated rescue medications. Imminent risk of injuring self or others or causing significant damage to the property. Suicide risk, suicide attempt within the past 2 years or investigator judged based on the psychiatric interview or information collected in the Columbia Suicide Severity Rating Scale. Treatment-related criteria including electroconvulsive therapy within the 3 months or non-response to ECT, treatment with a depot neuroleptic within 1 cycle or clozapine in past 10 years. Then requiring concomitant treatment with a prohibited medication. Example, any drug which has psychotropic activity except for lorazepam. It was given for agitation, irritability, hostility, and restlessness. Zopiclone, S-zopiclone, zolpidem extended release, chloral hydrate, or zaleplon for insomnia. Diphenhydramine, benztropine, or propranolol was given for extrapyramidal symptoms or akathisia. And the women could not be pregnant or breastfeeding and must be sterile or practicing a reliable method of contraception. Now about the efficacy assessment. The primary efficacy parameter which was used was the time of first relapse during the double-blind treatment. That was the primary efficacy parameter used. Patients who did not meet the relapse criteria, they were considered censored at the time of completion or discontinuation from the study. And the relapse was defined by objective rating scale criteria and the subjective clinical measures. Patient meeting any relapse criteria was discontinued from the study. So the relapse criteria, if the patient meet any one of these, they should be considered, they were discontinued from the study. Rating scale criteria, increase of more than equal to 30% in PANSS total score for patient who scored more than equal to 50 at randomization, or more than equal to 10-point increase from the patients who scored less than 50 at randomization. Second was score more than 4 on any of the 7 PANSS items assessed at randomization, and clinical global impression severity score increase more than equal to 2 points from the randomization. If any one of these would be met, the patient was discontinued from the study. And the clinical relapse criteria, which was investigator judged, it include psychiatric hospitalization due to worsening of schizophrenia, deliberate self-injury or aggressive or violent behavior, clinically significant suicidal or homicidal ideation. Now, the additional efficacy parameters which were used were positive and negative syndrome scale, clinical global impression severity scale, clinical global impression improvement scale, all the open label visits, all the double blind study visits through week 32 and every other visit thereafter. Then another which was used was negative symptom assessment scale, personal and social performance scale. Safety for the safety assessment, spontaneous reported adverse events, vital signs, clinical laboratory test, electrocardiograms, physical and ophthalmological examination, CSSRS, that is Columbia's suicidal severity rating scale to assess the suicidal ideation and behavior, abnormal involuntary movement scale, Barnes akathisia rating scale, and Simpson-Angus scale was used to assess extrapyramidal symptoms. For the statistical analysis, the primary efficacy analysis compared the time of relapse between the placebo and the cariprazine using the log rank test. So for the safety parameters, they were analyzed descriptively for the safety population. Now, what is the safety population? In open label, these are the eligible patients who took more than equal to 1 dose of the open label cariprazine, and in the double blind, randomized patients who took more than equal to 1 dose of the double blind study drug, that is either cariprazine or placebo. And the efficacy outcomes were analyzed in the intention to treat populations. In open label, the open label safety population patients with more than equal to 1 post-baseline PANASS assessments during either open label phase, and during the double blind safety population patient with more than equal to 1 PANASS or CGI assessment during the double blind treatment. For the result, patient disposition, a total of 1,149 patients were screened, and 384 of them they failed the screen test. Then for the run-in safety population, there were 765 patients left, out of which 501 patients discontinued. Maximum number of them discontinued due to the adverse events. Then the second reason was insufficient therapeutic response. Then some due to protocol violation, some due to withdrawal of the consent and loss to follow-up patients. Then only 264 patients were there and completed the open label phase, after which, out of which 64 patients discontinued, and the reason for discontinuation were withdrawal of the consent, protocol violation, loss to follow-up, and the criteria were not met. Now the patient were randomized to double-blind cariprazine, which were 101, and the other were placebo group, that were 99 patients. In the cariprazine group, the patient with completed the double-blind phase were 18, 25 patients relapsed, and discontinuation other than relapse due to adverse event were 6 patients, protocol violation by 5, withdrawal of the consent by 15 patients, and loss to follow-up of 5 patients. In the placebo group, 16 patients completed the double-blind trial, 47 patients relapsed, and discontinuation due to other than relapse, they were in total 36 patients. So the open label phase, it included a 8-week run-in phase and 12-week stabilization phase, and includes patients that did not meet the criteria to continue into the open label stabilization phase. So during the open label treatment, the most common reason for discontinuation was the withdrawal of the consent. 20% of them, it was due to the withdrawal of consent. When inquired to ensure that adverse events were not the reason for discontinuation, some patients indicated that they were unable to continue due to the length of the study. So most common cause was the discontinuation, and mostly discontinuation were due to the long length of the study, which was around 92 weeks, and the time commitment which was involved in that. Most demographic characteristic was similar among the groups, except for the male and female distribution in the double-blind phase. In the double-blind phase, men are 70 and women are 29, while in cariprazine group, men are 62 and women are 39. So mostly in the double-blind phase, most of the population, the more number of population were that of the males than the females. So for the efficacy analysis, this one, it is the cariprazine group of 3 to 9 milligram per day dose, and this one is the placebo group. And the time of relapse, it shows the cumulative index, and here's the duration of the double-blind treatment in days. We can see here that the patient on the placebo group, they relapsed earlier than those which were in the cariprazine group. So the cumulative rate of relapse, the 25th percentile for time of relapse was 92 days for the placebo group and 224 days in the cariprazine group. And in the 50th percentile, it was 269 days for the placebo group, and it could not be calculated for the cariprazine group because of the low number of relapse events. So at the end of the open label treatment, mean improvements in the PANASS total and subscale scores, CGIS scores, NSA score, and personal and social performance score was seen. At the end of the double-blind treatment, scores on these scales worsened to a greater extent in the placebo-treated patients than for the cariprazine treated patients. In the double-blind phase, these are the placebo-treated patients and cariprazine treated patients, and the scores they have worsened to a greater extent in the placebo-treated patients than in the cariprazine. Like the baseline in the PANASS score for placebo was 50.5, and the mean change standard deviation was of 13.2, while in the cariprazine group, the baseline was 51.3, and the mean change of standard deviation was only 5. In clinical global impression CVIT score, in the double-blind treatment, the baseline was 2.6 in the placebo group, and the mean change was of 0.7. And in a cariprazine group, the baseline was 2.8, and the mean change of deviation was only 0.1. In personal and social performance scale, the baseline for placebo group was 68.3, and mean change was minus 7.2, and for cariprazine was 66.8, and the mean change in that is standard deviation was 0.0. Now, for the safety, these were the adverse events that occurred. A zero number of death occurred in the open label and even in the double-blind phase. Treatment emergent adverse events, they were 612 in open label, and in the double-blind phase for placebo, it was 64, and for cariprazine, it was 75. And the adverse events which led to discontinuation, in placebo group, it was 15, and for cariprazine group, it was 14. Serious adverse events, they were 14 in placebo group and 14 in cariprazine group. And newly emergent adverse events, they were 64 in the placebo group and 71 in the cariprazine group. The only serious adverse event that was reported in more than equal to 2% of the patients during the open label treatment were worsening of schizophrenia. It was reported in 2.9% of the patient during double-blind treatment. Serious adverse events reported in more than equal to 2% of patients in either placebo or cariprazine group respectively were worsening of schizophrenia. It was 7.1% for the placebo group and 6.9% for the cariprazine group. This was the incidence of treatment emergent significant changes in the lipid and glucose during the double-blind treatment period in the safety population. And in this, the normal at the baseline for the cholesterol, we have considered less than 240 milligram per day, and post baseline more than equal to 240 milligram per day. In the double blind, we can see that in the placebo, it was 6 out of 89, and in cariprazine, there was 12 out of 92. So the major change which we can see in that more of the cariprazine group patients they got deranged lipid and glucose profile according to this table. More of the cariprazine, the patients which were using cariprazine, in them the lipid and glucose profile was more deranged. And similarly, if we see the liver biochemistries and metabolical other biochemistries, the more changes they were seen in the cariprazine group as compared to the placebo. In the open label phase, only cariprazine was given, and in the double blind, placebo and cariprazine was also given. So in the placebo group, there was not much changes in the liver and the other biochemical functions, but in cariprazine patients, there was significant change. Now the treatment emergent extrapyramidal symptoms. In open label treatment, the incidence of rating scale derived treatment emergent Parkinsonism that was seen by Simpson-Angus scale scored less than equal to 3 at baseline and more than 3 at any post-baseline assessment. And akathisia assessed by Barnes akathisia rating scale scored less than equal to 2 at baseline and more than 2 at any post-line assessment. It was 16.1% for the cariprazine group and 21.0% for the placebo group. During double-blind treatment, more placebo-treated than cariprazine-treated patients reported treatment-emergent Parkinsonism, 8.1% for the placebo group and 5% for the cariprazine group. And akathisia was seen in 10.1% of the placebo-treated patients and 8% in cariprazine-treated patients. Among cariprazine and placebo-treated patients, anti-Parkinson drugs for extrapyramidal symptoms, it was used in 19.8% and 19.2% respectively, and propranolol for akathisia was used in 10.9% of the patient and 8.1% of the patient respectively. Rescue medication, overall 193 patients, that is 25.2% of the patients received lorazepam as rescue medication for agitation, irritability, hostility, and restlessness during open label treatment, with use decreasing over the time, that is 22% during the first 2 weeks and 1% by week 6. During double-blind treatment, 8 placebo and 6 cariprazine treated patients received rescue medication, lorazepam or oxazepam. Suicidal ideation and behavior. According to Columbia Suicide Severity Rating Scale findings, suicidal ideation was reported in 29 patients during open label treatment, in which the patient just received cariprazine, and in 2 patients in placebo and 1 in cariprazine treated patient during double-blind treatment. Most reports were in the least serious categories, that is, wish to be dead, non-specific suicidal thoughts. Suicidal ideation adverse events were reported in 11 patients during open label treatment. 5 events were considered as serious adverse events, and no suicidal ideations, treatment emergent adverse events were reported during the double-blind treatment. So this relapse prevention study examined patients with schizophrenia who completed 20 weeks of open label cariprazine before randomization to continue treatment with cariprazine or placebo for up to 72 weeks of double-blind treatment. Patients randomized to cariprazine versus placebo had a significantly longer time to relapse and significantly lower rates of relapse, that is 24.8% for cariprazine and 47.5% for placebo. Although comparing relapse rates among antipsychotic agents is difficult due to lack of consensus about what constitutes relapse in schizophrenia, the time to relapse for placebo-treated patient in this study appears to be longer than in other relapse studies. Only 3% of the placebo patients relapsed during the first 4 weeks of double-blind treatment in our study, suggesting that some residual treatment effect may have persisted after cariprazine was discontinued. And to provide context for these results, estimated relapse rates in a meta-analysis evaluating 1-year relapse in schizophrenia were 27% and 64% for antipsychotic drug and placebo. And in that analysis, oral and depot, both the agents were used, and the depot preparations reduced the relapse more than the oral. Low rates of relapse in the first month after discontinuation of cariprazine, it may be related to its longer half-life related to other antipsychotics, which almost all have a plasma half-life of 1 to 2 days. In contrast, while the calculated effective half-life for cariprazine and desmethylcariprazine was approximately 2 days, it was considerably longer for di-desmethylcariprazine metabolite, 8.4 days, and the total active moiety is to be 1 week. Although relapses can be decreased by uninterrupted pharmacotherapy, the majority of patients with schizophrenia are at least partially non-adherent to the medications. Since tolerability issues contribute to medication non-adherence, it is important to note that cariprazine was generally well tolerated in this long-term study, with the vast majority of adverse events considered mild to moderate in severity. Severe adverse events and adverse events that lead to discontinuation were most commonly associated with worsening of the underlying psychiatric condition. Akathisia, the most commonly reported treatment-emergent adverse event in open-label treatment, was mild or moderate in the vast majority of patients during the study, It accounted for discontinuation of only 1% of the patients in open label treatment and no patients in the double blind treatment. So the conclusion, in this relapse prevention study in patients with schizophrenia, the time to relapse and rates of relapse were significantly lower for cariprazine versus the placebo. The hazard of relapse for cariprazine treated patients was calculated to be less than half that of the placebo treated patients. Mean scores on additional efficacy parameters suggested symptom improvement for patients taking open label cariprazine and less worsening of symptom for double blind cariprazine treated patients than for the placebo treated patients. The long-term safety profile was consistent with that observed in previous cariprazine clinical trials. Results from the trial suggest that cariprazine may be useful in delaying or preventing relapse in schizophrenia. So the limitation of this study was the lack of an active comparator, low number of open label completers, as very less number of individuals they were to qualify the open label phase. Long duration of the study, that is up to 92 weeks. And the double-blind population had already been stabilized on cariprazine, as such patients with unacceptable adverse event or tolerability problems during open-label treatment were not part of the double-blind analysis, and the double-blind adverse event profile should be interpreted with caution. Critical appraisal. Title of the article appears clear and concise, states what they want to study. Author, the funding was received, conflict of interest were present, and the aim, it clearly describes the purpose of the study. However, the time of the duration, it was not mentioned. What's the 72 weeks and 90, 70.
26 weeks to the becomes the open label one.
Sir, the first randomized patient, whenever he completes, the last randomized patient completes 26 weeks. So at that time, the study will be all the patients.
26 weeks is the other inlet where first study the way gets very later लोग भी मिलके ट्रायल करें तो जैसे कि ये क्या Unit trip for building self-aware or body significant. Okay. ये सुसाइड इसके लिए होंगे कोलंबिया सुसाइड ट्रिप वेरी फैसिलिटेटिंग स्कीम किया है इसमें इंटरेस्ट स्कूलिंग रेटिंग से ज्यादा होती है इट इज जस्ट वेरी लेकिन वो ठीक ही है पर मान लो इसमें सुसाइड गेट तो यहाँ पे देयर वेरी इट वाज ड्यू टू सेकेंडरी टू से इसके हम पेशेंट का ज्यादा से पहले है या किसी को स्ट्रेस हुआ तो impulse किया तो वो इन्वेस्टिगेट होता है if there's someone this is an investigate problem this is the society it will make there is more discovery for most many है ठीक है या आपको पता है कि उसको फेल हो गई है it's standard procedure a letter for some letter investigate treating the patient so then what you get आपका एसोसिएशन basically flexible tool बस ठीक है ये क्या है बिल्कुल दोस्त क्या है बिल्कुल ऑटोमेटिक नंबर कम करने की वही लोग उन्होंने शुरू में इसको स्टेबलाइज करने के लिए के लिए फिर वो अब आपने उसको फिक्स पे लगा तो आपने रनिंग कर लिया पहले फिर के लिए तो इसमें भी फिर आ गया आपको पहले तो उसको कितना मैंने पता नहीं एक बार ठीक है नेक्स्ट वाले का हमने 10 पे उनको देखा हम पता नहीं आपको टेक्नोलॉजी से जरूर है तो पेशेंट का मैक्सिमम सेविंग किया है लेकिन तो ये जो हम लोग लेकर टेंशन करेंगे स्ट्रक्चर्ड वे में करेंगे ये उससे पहले आप तो चेंज कर सकते हैं पहले एक वीक से ये वीक का रिस्पॉन्स टेस्ट कहते हैं सीधा भी वो या फिर tested that it was feelings. He is still making feeling of the unstable feeling. वो stable stable therapy ऐसे देखो कोई पेशेंट होते हैं ऐसे करना वो stable उसकी ड्यूरेशन हर एक आदमी अलग होती है
This eligibility criteria from
this
one place to other.
से 765 को ही बचे थे आपकी को कंटिन्यू ठीक है एक कल तो स्पीड के लिए भी होगा उनके नॉर्मल डाल तो अगले होगा फिर 765 से 264 765 में से मुझे जो पहले तब उसके फिर 265 में से ठीक अभी बताओ तुम लोगों ने कहा नहीं ये है 5 तो 64 थे तो उन्होंने वहाँ पे 61 अदर्स है तो वो भी सूट कर रहा है फिर आपके ऑनलाइन में ये जाके for each country when they want they better skill इंडिया में बहुत ज्यादा पेशेंट केस इन फेज में और परेशानी क्योंकि उसमें था ना कि 2 वीक्स आपको हॉस्पिटलाइज लेना है पहले वाले में फिर 2 वीक्स आपके पास है वो है ऑप्शन है ऐसा तो नहीं है यहाँ रखी रही होगी 4 हफ्ते के लिए तो बहुत ज्यादा आ गया तो बहुत लोग end up laid off. So they had to explain to already so they tap found that about they were crossing that so they had to discuss नहीं ओपन लेवल वाले randomized से close to 64 patients. He started from 764 patients are actually coming in the open label stabilized patient. So this is what is it is a sleight of hand. Yes, लगता था ऐसे कि इस कैरेक्टरिंग का रिस्पॉन्स होना चाहिए 45% भी रिलैक्स है ऊपर में रिलैक्स हो गया उसके पहले की ऑल्सो ये भी फिल्टर भी है एक बार में ट्रीटमेंट के लिए यूज हो जाता है ठीक है तो यही मैं बोलता हूँ तो मुझे जैसे चार्ट हो कितने स्क्रीन किए कितने गया है तो कितना कैसे वैलिडेट क्यूरियोसिटी तुमने सिर्फ कहा कि मैंने 200 पेशेंट नीचे कर 200 पेशेंट ये आधे प्लासिबो में आधे इसमें तो वो कहेगा कि कैसे आपने पेशेंट की अगर चार मतलब ये स्टडी देखते तो यहाँ से शुरू कर तो पेशेंट यहाँ से आ सकते तो ये जो तीसरा प्रोसेस है पूरा जो हमने बेसिकली एनालाइज किया तो डेटा तो यही किया This all write-up is to give credence to the data to see these are patients. At least stability of diagnosis is there. The best questions about whether they have schizophrenia. आप तो बताओ इस चार्ट से तुम बता सकते हो can you raise a question on the diagnosis? क्या कैसे like if you say that out of these patients or maybe some of them have some of them are having active psychosis they maintained and they kept on condition कैसे कैसे कर प्लसीबो में कितने कंप्लीट किया प्लसीबो में कितने पेशेंट्स थे कंप्लीट 16% 16% पेशेंट वर completed the study और कैरेक्टर्स इन द 17% इतने परसेंट लोगों ने किया ही कंप्लीट आप ये सोचो प्लसीबो में किसने 60 वीक तक प्लसीबो पे वो रिलैप्स ही नहीं किया I would say that if some this patient who was on like without any he was on placebo, then I would say that maybe he was not any. The same is true for cariprazine also. और जो relapses है वो बहुत ज्यादा है बेस में 47 रिलैप्स हो गए, यहाँ पे 25 रिलैप्स। ठीक है, फिर ये है कि यहाँ पे 25 रिलैप्स हुए, 18 वहाँ पे 47 रिलैप्स हुए, 18। एंड द ट्रू पिक्चर इज कि ये इन्होंने एनालाइज नहीं करके डिसकंटिन्यू ड्यू टू अदर प्रॉब्लम्स। व्हाट आई वुड लाइक टू नो इज कि डिसकंटिन्यू टू अदर प्रॉब्लम, यहाँ पे विड्रॉल ऑफ कंसेंट 50 के जो अदर्स है यहाँ पे 27 और वहाँ पे अदर्स 11। ये एक सिग्निफिकेंट डिफरेंस है। ये क्या है? ये ऐसा तो नहीं कि करते somehow जैसे ओवरलैप्स में उसको भी ट्राई टू क्लासिफाई। if you put those 27 also there in 25, then it becomes अदर्स क्या है? ये अदर इज वास्तु टैक्स। सबसे इम्पोर्टेंट है फर्स्ट ऑफर साइड पे आओ, their applications. There's a lesson fast. You can see the application of ठीक है, इसमें वैसे यूजली जैसे को भी बना so Gideon से associated हुआ है। ठीक है, then Nasrallah is a person in Indian research. They have taken some experts. Most likely these are the people who have American people have collected the data and these people have taken the data. This was the last of the expert. So last of the take an expert to give you a message to data. The application of the principle of the is from the journal. They are published. First of all, उसमें ये होता है कि जैसे कई बार आरसीटी कई बार मेंशन किया कि कौन सा ये इनका आरसीटी का रजिस्टर्ड था मतलब ट्रायल नहीं बताया कि आरसीटी की रजिस्टर्ड थी कि नहीं थी आरसीटी का डेटा।
Sir, they have just told they have registered, but they haven't
given
mentioned where.
Because if you go there, then you will see the true data. But actually, all the data is share करना पड़ेगा। रजिस्टर्ड में जैसे हम लोग पब्लिश करते हैं, that is not given. And comparative, if I have a comparative here, then we can have definitely calculating the lapses, whatever they have to do with calculating group, they will have to do with the comparative group also. As in terms of statistics, so maybe calculating will come up with. जो withdrawals है उसमें भी akathisia बहुत high है, so 80%, 80% patients have reported.
Okay.
19.2 is open label and people budget
So treatment
80%.
edge more than 80%. On characteristics. In sir,
Double blind
double blind
will-
also carry present more sir. Carry present.
more statistics. थोड़ी जैसे ही सीरियस
Serious adverse.
क्या क्या होता है कैसे any patient who is hospitalized more than 24 hours or any patient at the risk of losing his life or his limb. Okay. So अगर आपका पेशेंट अगर उसको वैसे भी एक्सीडेंट हो जाता है तो दिस यू हैव टू रिपोर्ट नो मैटर व्हाट अगर वो डायरिया लेके भी एडमिट हो गया तो आपको ऐसे ही रिपोर्ट करो फिर आप ये कर दो ऐसे ही वाज नॉट सेकेंडरी टू द आईपी या जब मान लो कोई गिर गया फ्रैक्चर हो गया फ्रैक्चर हार्ट टूट गया प्रेगनेंसी अगर होगी दैट इज आल्सो patient on clinical time without pregnant. So loss of limb or say 24 hours of hospitalization. This has to be reported as safe. तो वो आपका होता है फिर आपको एथिक्स कमेटी को करना पड़ता है आपको डॉक्टरों को बताना पड़ता है हमारे यहाँ पे ऐसा हो गया पेशेंट इसमें जो है ऐसे ही जो पेशेंट साइकोसिस पर्सन होगा जो पता है कि उन्होंने ऐसे ही
Sir, SAE was that one, sir, in which the worsening of schizophrenia according to
जैसे हॉस्पिटलाइज करना पड़ा था जैसे उनको साइकोसिस लैब्स किया उनको एडमिट किया तो ऐसे ही pregnancy is considered as a serious adverse event नहीं है but the thing is कि you have to report it as an issue. It is a वो फॉलो करना पड़ता है कि भाई आपको पता नहीं क्या क्या उसका उनके ट्रायल तो हम लोग कर नहीं सकते प्रेगनेंसी पे क्या असर पड़ता है एक्सीडेंटल एक्सपोजर हो गया then that has to be developed in the birth of the child or in the condition तो उसमें in the form of pharmaceutical तो पेशेंट तो वैसे किसको नहीं बोलेंगे फिर उसको प्रेगनेंसी में तो नहीं दे सकते इन्वेस्टिगेशन होगा तो बट दैट आउटकम विल बी फॉलोड they have you have to keep on reporting to the extremity and to the DCPI so nothing is being affected तो it's a great news हमारे स्टडी चल रही है तो उसमें तो लाइक होते ही ऐसे ऐसे से लेंथ ऑफ स्टडीज तो ईयर इट्स अ 1 ईयर स्टडी जैसे 36-40 वीक्स आ रहे हैं तो सारा पेशेंट ऐसे से एक हफ्ते होते क्या है ना आप शुरू में दे paradoxically those people who are doing better they are now less ठीक है और ठीक चल रहे हैं आप नहीं आगे ऑलमोस्ट ये रेस्क्यू मेडिकेशन रेस्क्यू मेडिकेशन बता काम दे सकते हो बेस्ट दे सकते हो कॉन्फिडेंट ये रेस्क्यू मेडिकेशन तो हम लोग दे रहे हैं इसको
it what does it have?
not familiar with second episode of diazepam स्केल सारी हमारे पास इसके लिए सीएस का रियलिटी के लिए बार्स एसएस एनीबॉडी the second is visual performance based. So definitely whether it reflects CJ, fans CJ, some visual performance. Right. So there is- It's like CJ. Line, requires objective. Your case is pending down.